So everyone can see my screen. They can see the adaptive athletes chapter. Perfect. So pretty much to introduce this chapter, we are seeing more and more adaptive athletes. So what does adaptive athlete mean? What do we think about when we think about an adaptive athlete?
Maybe an athlete that has an impairment.
Okay, so an impairment. So what kind of impairments would we consider?
Maybe a disability or something like that.
Okay, so somebody with like cerebral palsy, Down syndrome, blind people can be an adaptive skier. Or what we're seeing a lot of are skiers that have limbs missing. So for example, they've got legs missing or arms missing, and they need some kind of special rigging device, or they're paralyzed and they need some kind of special rigging device in order to enjoy the ski slopes. So that's what we're going to be talking about tonight is adaptive athletes, and those athletes that do require a little bit more attention than your standard skier on the ski hill. All right, give me 1 second. I'm trying to get my keyboard set up. All right. So we've gone over these throughout the entire class. We have our objectives that we're going to be going over today. Key terms. All right. So pretty much like we talked about, many athletes have impairments. However, they are still able to compete and participate in sports. However, these can be social or physical barriers that these athletes may face while participating outdoors. So certain factors can determine whether a person impaired can participate in a sport. These include active participation usually requires mental ability equivalent to performing activities. So, if they're able to dress themselves and brush their teeth, they're able to perform at the ski resort. There's passive participation, which requires less physical and mental ability. So this would be, for example, like sitting in a sit ski. So that's basically a device that they're able to sit into and somebody else runs it. And physical participation depends on the person's balance, muscle strength, coordination, and neurological processes. So impairment of one of these functions can make active participation difficult. So for example, you have a patient that is paralyzed and they don't have the ability to balance or the muscle strength. It's going to make their ability to participate in a sport much more difficult. So people can have both intellectual or physical impairments or both. Intellectual impairments involve a learning disability or psychosocial or personality problems. And they can also include the inability to see, hear, or become aware of something that using the senses makes life more challenging. So participation in outdoor sports is becoming more and more popular. Like I said, we are seeing more and more of these skiers out there as they are joining us in the skiing and snowboarding community. So there's new materials out there that is making the equipment much more reliable, much more sturdier. We're also seeing many young military veterans with traumatic and physical physical problems and brain injuries that want to be active in recreational sports. And there's outdated thinking regarding recreational opportunities appropriate for athletes with impairments that are now being challenged. So as OEC technicians, we must know how to respond appropriately to individuals, and they can be unique. These patients, I'll say I can't recall over the years, like I've seen them, I've seen adaptive athletes at our resort. I can't recall really treating anybody. I know Martha's on the line. Martha, have you had to treat any adaptive athletes over the years at the resort?
Not any that I can remember that were physically impaired, but a few that might fall into next chapter, like behavioral / you're not sure what their real mentation is.
Exactly. Yeah. I mean, it's, these patients to us, at least at our resort, make up a very small population. Where we see a lot of adaptive athletes are resorts that do have an adaptive athlete program. So, for example, we don't have a quote unquote adaptive athlete program. So, really, if somebody does come up, they've got their own equipment, their own resources, their own helpers to assist them.
Yeah, Sam, I'm sorry if I can butt in one more
Yeah.
time. Is I have definitely seen physically impaired, people skiing, and you're absolutely right. Usually they ski with a buddy. Most people do ski with friends so that they're kind of self-sufficient. And I did do the guiding, actually back in Purgatory when I worked there, for a bunch of sit skiers and some skiers that were missing their lower legs.
So that brings us to our last bullet point here is that oftentimes there's a guide or instructor or coach or companion with these individuals. And definitely, we want to be using those individuals as we're trying to assist the developmentally or physically impaired individual. So the terms to describe a person with limitation are important. So there's impairment, which is a loss of a specific physical, physiological, or psychosocial ability, or disability, which is any physical or mental condition that prevents a normal function or daily activity. People can have an impairment and not a disability, and many people with impairments are not disabled from many activities. So a handicap is a condition that markedly restricts a person's ability to function physically, mentally, or socially. Individuals with disabilities, whether generally or genetically inherited or acquired through trauma or illness, prefer the term disability to the term handicap. And then adaptive athlete is talking about somebody that participates in an outdoor sport or activity. And this is the official term that National Ski Patrol has developed. We should not be using the following terms: deaf, dumb, mute, retarded, crippled, lame. So different categories of physical impairments. So to start off, we have autonomic dysreflexia. This is the abnormal function of the nervous system that can lead to a dangerously high blood pressure. This can be potentially life-threatening in patients with previous spinal cord injuries due to a new problem below the level of the pre-existing mid-thoracic or higher spinal cord injury. This can be triggered by a variety of causes, including pinching of the skin, sunburn, a distended bladder or bowel, sexual arousal, and constipation. So these are some other causes of autonomic dysreflexia. If you take a look at your book on slide or on table 32-1, it will give you a more of a rundown of causes. With autonomic dysreflexia, this may initially present with feelings of panic or anxiety, which can cause a rapid increase in blood pressure to the dangerously high level. And the problem with blood pressure is that as it increases, if it gets too high, you can have a stroke. You can also have seizures, and you can also have cardiac arrest. So as the blood pressure increases, there's possibility of bursting blood vessels, which can lead to all three of those. Symptoms of autonomic dysreflexia include a pounding headache, dizziness, nausea, altered mental status, and blurry vision. Physical findings can include skin changes, such as sweating or flushing, dilated pupils, fluctuations in body temperature, a slow pulse below 60 beats per minute, and severe high blood pressure. So if we suspect it, we want to try to find a cause and correct it. So this would include taking off tight clothing. If they have a urinary catheter in place, inspecting the urinary catheter to make sure it's not blocked, and looking for other irritants. We can also have the patient urinate to relieve a full bladder. And when it occurs, we want the patient to sit up. Sitting upright helps move the blood to the lower body and eases the blood pressure. If we do suspect autonomic dysreflexia, we want to arrange for ALS transport. And even if we find the problem and correct it, we want to allow the patient to regain, or we want to allow the patient to regain normal vital signs, we should still initiate the transfer and for further medical care. So moving on to amputation. So this is talking more about previous amputations. If somebody has an amputated body part and it's acutely amputated, which means it happened at our ski resort, don't allow them to go back on the mountain. So this discussion that we're having today is somebody who is previously amputated. So an amputation they've had for a while. So this does make up the largest group of adaptive athletes. Amputations or missing body parts can be congenital, traumatic, or surgical in nature. And some people have more than one amputated extremity. Now, you will hear these acronyms when talking about amputations. So you may hear BK or AK. So BK does not stand for Burger King. Does not stand for Burger King. It stands for below the knee. So that means that they had the amputation below the knee, which means they still have use of their knee. Whereas AK is above the knee. So the relative impairment depends on whether it's an arm or leg and how much of the extremity was lost. Usually when they amputate, they try to amputate as little as possible. So what ends up happening is that you may see somebody that has an ankle amputation, or you may have somebody that has half of a calf amputation. Really just depends on what the cause of the amputation was. So some people have missing limbs from birth. They're able to easily adapt in life, and they use a variety of adaptive equipment and prosthetics to overcome the impairment. And a prosthetic is an artificial part that substitutes for the missing or impaired body part. So really quick, just talking about just the prosthetics. If you do have somebody with a prosthetic, please make sure that you take care of them, and those prosthetics are transferred with the patient. Many of those prosthetics are many of thousands of dollars. I can't remember, was it this group that somebody told me that they're in a previous chapter that their loved one has a prosthetic? I don't know. I've been teaching a bunch of disability classes lately, and I thought it was this group, but it may have been a different group where somebody told me that their loved one has a prosthetic, and they can run thousands and thousands of dollars. So please make sure that you take care of them and that you transfer that prosthetic with the patient. So talking about combined disability, so we can have combined physical and intellectual and cognitive disability. So people who have both physical and intellectual and cognitive impairments are usually a challenge when caring for them. So we want to use knowledge for both the physical and intellectual impairments. So one impairment category is Down syndrome. This is caused by the presence of an extra chromosome. I believe it's chromosome 23, if you want to be specific. Does that sound familiar? Or is it 21? Anybody know? Is it 21 or 23?
I don't know for sure, but 23 sounds right.
Yeah, for some reason, I want to say 23 is where that extra chromosome is, but it could be 21. But yeah, Kelly, I agree. 23 just sounds very, very spot on. So this results in physical and intellectual disabilities that widely range from one person to another. And the degree of physical impairment cannot be predicted by characteristic facial features, short stature, or pleasant nature. Individuals who do have Down syndrome, they should be carefully evaluated to avoid dismissing a potentially serious injury. So that means that we want to make sure that we do a proper and thorough patient assessment. But I would say just don't do a proper and thorough patient assessment on just people with Down syndrome. We want to make sure that we do it on everybody. However, individuals with Down syndrome are at increased risk of musculoskeletal injuries due to general hypotonia, which is a low muscle tone, and lacks ligaments. Specifically in the neck, the ligament that stabilizes C1 and C2 can be torn, which causes the instability of the upper cervical spine. All right, so moving into traumatic brain injuries. So we do have many individuals that are that have had prior traumatic brain injuries. And really quick, just to recap of this chapter in general, this is talking about individuals with prior illness or disease. So, we're not talking about, somebody who comes up and they go off a jump and now they suffer traumatic brain injury. We'll talk about that later. This is talking about the after effects of that individual. So people with traumatic brain injuries, they usually result from a violent blow to the head or body, or an object that penetrates the brain tissue, or brain tissue being deprived of oxygen following trauma, which allows brain cells to die. So the long-term effects can be divided into several categories, including physical, cognitive, sensory, perceptual, social, and emotional changes, or a combination of any of the above. And then we got sensory impairment, which includes visual or hearing impairment. So outdoor enthusiasts who are usually visually or hearing impaired represent a large percentage of adaptive athletes. And the age of onset can really occur really at any age. And it will also affect the level of their disability. In fact, we do have many patrollers, in the past we've had many patrollers that do have trouble hearing. And this seems to be very common as individuals age, having that hearing impairment. So talking about visual impairment, so blindness. These are often seen often on gentle slopes with guides acting as their eyes. So typically you won't see blind skiers in some of our crazier runs. They're usually on our more mellower runs, and there's usually a guide with them, as you see like in the photo, where they're easily identifiable. We see that the skier themselves is wearing a orange vest, and the guide is right behind them watching them with the vest on as well. However, blind skiers in the Paralympics can get to speeds of up to 50 miles an hour. And pattern of injury seen in blind participants in snow sports is the same as those with normal vision. So just because they're blind doesn't mean they have any special injuries that can occur. There is various terms talking about visually impaired individuals. So when we talk about somebody who is blind, the word blind generally refers to the total absence of vision or the ability to determine only the existence, not the source of light. Whereas a visual impairment is any vision problem that is severe enough to affect an individual's ability to carry out tasks of everyday living. Then you have low vision. These are people who are said to have low vision if they have severe visual impairment, even after the best possible correction, whether it be with glasses, contact lenses, or surgeries, but still have some usable vision. And then there's the term legally blind. And we run into this one quite a bit. This is somebody who has a vision acuity that is worse than 2200 with glasses or contact lenses are considered legally blind in the US. So just like any of the disease processes that we've talked about so far, visual impairment can take many forms and exist in varying degrees. As you can see, I've got a visual impairment, I wear glasses. So visual acuity or the sharpness of vision alone is not a good predictor of a person's vision problems. There are levels of visual impairment based on visual field loss, whether it be loss of central vision or peripheral vision. A person who has no peripheral vision may be able to read with a combination, but not be able to drive. All right, so common causes of blindness in children include a congenital cataract, retinopathy or of prematurity, vitamin A deficiency, measles, and albinism. What do you think the chances of seeing measles these days are? Or what do you think the chance of seeing somebody blind from measles?
Low.
Yeah, pretty much eradicated measles. So I'd say that'd be very low. There's other causes of impairment, which can include uncorrected strabismus or crossed eyes and uncorrected, I'm not going to try to pronounce that, but basically a lazy eye. So individuals with crossed eyes or lazy eyes can have visual impairments. About 60% of children born with visual impairments have other impairments and are classified as multiply disabled. Older adaptive athletes may be visually impaired due to glaucoma, head or eye injuries, diabetic retinopathy, cataracts, corneal disease, macular degeneration, optic nerve disease, retinal damage, or multiple sclerosis. So moving into hearing impaired individuals. So individuals with hearing impairments can generally participate in any outdoor activity without too much difficulty. They can usually read lips, but they must be able to see our mouth clearly. So why is that a problem in today's day and age?
Because we have to wear masks.
Yeah, they gotta wear masks everywhere. However, they are making clear masks specifically for this problem. What's the issue with clear masks?
Made out of plastic. They're usually made out of plastic and not cloth.
And Dean, what's the problem with that?
It doesn't stop the droplets or the air. All it does is just block the air. It just sends the air out the side. It doesn't stop the air.
Depending on the mask, you are right. So if you wear a face shield, then yeah, it'll just move that air. However, you're still able to see. But with plastic masks, I've actually seen fully plastic masks for visually impaired people, or hearing impaired people. Problem is that how do you breathe out of it if you have plastic surrounding your face? So many people who are hearing impaired do have speech problems and may choose to not communicate verbally. Some deaf individuals use sign language fluently to communicate with others, and often adaptive athletes' companions will know sign language and be able to assist or act as a translator for the OEC technician. There's a couple different types of sign language. We've got American Sign Language and British Sign Language, and they have their distinct languages with their own unique alphabet sounds and grammar. So people who are hearing impaired may be able to hear some part of speech and sounds around them. If they can barely hear any sounds at all, they are considered to be profoundly deaf. And deaf people may be able to hear a few environmental sounds, but can't understand speech, even with assistive technology. When we talk about assistive technology, what are we referencing?
Hearing aids.
Hearing aids. And with hearing aids specifically, the concern is them falling out, and they are very expensive. So make sure if you're going to treat somebody that you make note as you're doing your assessment if they have hearing aids in place. And the problem is if they lay flat, sometimes the hearing aids can fall out, which can be a problem on the ski slopes of maintaining those. So please make sure that you are maintaining and you're recognizing whether or not somebody has hearing aids in place. So hearing problems at birth or congenital hearing loss are rare. Occurs in fewer than 3 out of 1,000 newborns with that have a moderate or severe hearing problem, but can be caused by inherited neurological premature birth or birth trauma. Can also develop in childhood following illness such as meningitis, tumors, medical reactions, consequence of medications, or other repeated severe middle ear infections. So problems are particularly common in older people due to age or accumulated lifetime environmental noise exposure, such as loud machinery or rock music. Specifically in the medical, actually I don't go medical, specifically in the pre-hospital environment, and you may see this on ski patrol, where might we see repeated lifetime environmental noise exposure with some of our fellow ski patrollers?
Ride snowmobiles.
I like that one, riding snowmobiles. But I'm going with something else, and it's not really related to the ski area. However, we do have a lot of patrollers that have this specific type of job.
Firefighters.
Firefighters or paramedics, right? So emergency workers, and it's from the constant use of the sirens that can affect our hearing. And then specifically talking about the ski resort, one of the things at our ski resort, is we do not have power from NV Energy at our ski resort. We generate all of our own power through big diesel generators right below our ski patrol shack. So our lift maintenance people, you know, they're not wearing the proper hearing protection around those generators, then that can lead to repetitive, or that can lead to that accumulated lifetime environmental noise exposure and hearing loss by repeated or by repetitive exposure to that generator. So the use of hearing aids or a cochlear implant can assist many people with hearing problems, although they may not always wear these devices while participating in outdoor sports. Like I said, the concern is losing them, and being in a outdoor environment, it's very easy to lose those devices. All right, so moving into intellectual and cognitive disabilities. So cognitive ability refers to conscious mental activity, thinking, reasoning, or remembering, and they might be learning disorders, attention deficit or hyperactive disorder, dyslexia, autism, mental illness, or post-traumatic stress disorder. Cognitive disabilities results from any loss of brain function that limits the ability to process information. All right, so now going into some of the specific medical equipment and aids that we may see. So there may be various medical equipment used by adaptive athletes with physical impairments that can be generic or custom. So many have generic devices such as catheters, collection bags, and special clothing. So when we talk about catheters, these are inserted into the urethra or lower abdomen just above the pubic area, connected to an outside bag that may collect urine. Patients may also have an ostomy bag, which is a clear bag that enables the collection of feces through a surgically created port in the abdominal wall. There may also be a urostomy, which is a surgically created port in the anterior abdomen or the kidneys that drains the urinary system. You may see compression stockings, which may help with swelling of the legs. And some athletes may have stool and urinary incontinence and wear diapers. So specifically let's talk really quickly about catheters. Catheters are very easy to pull out. And so the concern that we have with those is making sure that, we're not tugging or pulling on them, as those can easily become dislodged. Then we have some custom aids. This would include special types of wheelchairs, legs, custom tricycles, artificial limbs. The concern with any of these custom parts is that they are very expensive. So we want to do every effort to make sure that these go with the patient to the hospital, or that they remain with the patient. Prosthetic legs come in many designs. There may be only an ankle joint. They may have both a knee and ankle joint. And really it depends on where the amputation was performed. And many of them have electronic components. And some prosthetic legs are designed for specific sport. So for example, amputee skiers that ski on one leg with two outriggers may wear a brace on their good leg to decrease the risk of strain or injury. Prosthetic arms may have a hook-shaped pinching device that enables objects to be grasped and manipulated, or a strictly cosmetic non-functioning hand can replace the hook on some prosthetic arms. Newer prosthetic arms may have hand-controlled by computer chips that can open and close and look and function very similar to the real thing. People may walk with canes to either help them with balance or to partially unload the weight onto one leg. So by acting as an extension of one arm, a cane aids balance by giving its user a third point of contact with the ground. And a cane can be used on the same side of the affected leg to allow some weight to be transferred to the leg, from the leg to the cane. You may also see crutches, which can bear a lot of the body weight by the hands and wrists and transfer through the arms to the shoulders, or give some weight to the armpits. To use crutches effectively, the person must have good upper body strength. Most adaptive sport crutches, such as ski outriggers, are a modification of these crutches. And outriggers aid mostly with the balance and some weight transfer. You may see some wheelchairs up at the ski resort. Specifically at our ski resort, individuals who come up in wheelchairs The issue we run into is getting up to the upper decks of our area. We just installed an elevator into our new main building that just got developed. However, our older buildings don't have wheelchairs or elevators to accommodate wheelchairs. So we really don't see many people that come to the resort in wheelchairs. Martha, have you had much experience at our resort with people with wheelchairs?
Negative, Sam. You're absolutely right. With the new design, it's even worse.
Yeah, exactly. If you haven't seen our new design, there's now steps that go up, and yeah, and then also too, getting to our resort, individuals on wheelchairs, they've got a huge hill they got to go down or up on the way out. There's no, not really paved. It's I believe it's still dirt. So very difficult for individuals in wheelchairs to get to our area.
Even so, actually, it reminded me that there were some wheelchair skiers that came through and used the base area, or not the base area, but the far area to get on their ski and go up the bunny hill and then attack the area from there.
Oh wow! I didn't even know that happened up there. But yeah, I mean that would be an accommodation for those individuals. Which speaking of accommodations, as a ski resort, we rely on customers, and so we want to be very customer service oriented. So as Patrol, you represent the ski resort, so we want to make sure that we are making accommodations when possible. All right, so a sliding board. This is a smooth, flat board, approximately 12 inches wide and 3 feet long. This can be used to assist somebody to transfer to a wheelchair, and these may be used by the disabled person alone. Others may use a sliding board or may slide the person after performing a total lift onto the board. And those with little to no leg muscle function may additionally use a sliding device to move while sitting. And then we have a ski bra. This is a device that attaches to the front of the ski and holds the skis at a fixed distance so the tips don't cross or spread apart. Then we've got a sit ski. This is kind of a bucket device that adaptive skiers can sit into. It can have 1 or 2 skis to attach to the bucket. Then there's ski spreaders, which is a bar placed under the heels of the adaptive athlete ski to keep the rear of the ski separated and fixed, often used in conjunction with the ski tip tethers to facilitate a stable ski wedge stable wedge ski position. Then there's ski standers, which this is a device that attaches to the skis and utilizes a waist harness and armrest to help support the adaptive skier in a standing position. And then we've got 3-track adaptive skier, which uses 2 outriggers plus 1 skier board, or a 4-track adaptive skier, which uses 2 outriggers plus 2 skis. So we see here, this individual in the photo, we see here that they're missing their leg. So this is 1 ski with 2 outriggers.
They may be missing their leg, but they're shinning that game.
Right?
Right? If there's any racers in the crowd, that's a good line.
So the equipment and prosthetic devices used by adaptive athletes can be very expensive, so we want to make sure we take good care of them, make sure that they remain near the athlete. All right, so moving from equipment, we're going to talk about some communication strategies to talk with these individuals. So some communication strategies for those with physical impairments. So adaptive athletes with physical impairments generally communicate as any other individual would, but their level of anxiety may be higher. I can tell you from running 911 calls in the Valley, physically impaired individuals, I wouldn't really go and say their level of anxiety is higher. I mean, if they're physically impaired, but they're there cognitively and mentally, the level of anxiety is usually about the same for really any just physically impaired individual. However, good communication provides the best basis for understanding and is one of the hallmarks of a highly trained rescuer. So we want to make sure that we're communicating and using good communication techniques. And this includes addressing the patient at an appropriate level for eye contact. Regardless of whether or not the patient is physically, mentally impaired, or whether they don't have any impairments. One of the things I don't like to do is I don't like to stand over a patient. I feel like I'm talking down to them. So we want to go ahead and I would say not just for physically or mentally impaired individuals, but for all individuals. Consider getting down to their level in order to talk with them. OEC technicians can gain the confidence of an injured or ill adaptive athlete if they ask how they can help and how best to care for them and their equipment. This one's really big. Asking individuals, how can I help you? Or, do you want help? Or what's the best way to assist you with whatever the case may be? We want to communicate with the patient's companion, relative, or caregiver because many times they have very important information that can guide your care. Not only do they have information about how the ski equipment works, they may have information as how to best communicate with the individual, and they may have very important information about their prior medical history, medications they take, and information that will be important to your assessment. So moving into intellectual disabilities are likely to affect communication. So we always want to attempt to talk to the adaptive athlete first. If they have a severe disability, we may need to rely on their companion to answer history-related questions regarding assessment and to get a complete sample history. Intellectual disabilities may slow an adaptive athlete's ability to understand or respond to questions and appreciate the importance of scene safety. So try to kind of think about this last bullet point here. Appreciate the importance of scene safety. I'm just gonna move on. So we want to make sure that we use clear and concise communication. We want to use simple, direct, and polite sentences. We want to present one question, instruction, or one statement at a time. I'll have to say this one, this strategy is very good for all patients. We don't want to overload them with any information, but more specifically intellectual disability individuals. But like I said, for all patients, try to give them one question at a time, one statement, one instruction, and not to overload them. We want to avoid phrases that have more than one meaning or include difficult medical words. I don't like getting into, for all levels, providing them with, medical jargon. I prefer to just speak plain English to somebody, and I just find that it just alleviates a lot of that anxiety. And with people with intellectual disabilities, open-ended questions may be too difficult, so we want to stick to yes and no or very simple questions if possible. We want to avoid frightening patients by making sudden movements or speaking in a loud voice. On-scene stimuli, such as those from snowmaking equipment, can distract patients. We want to direct other rescue team members to manage any distraction in and around the scene. These adaptive athletes may be extra anxious that your treatment will cause further pain, so we want to be very gentle with them. And we want to establish personal space boundaries or understanding the need for a physical exam may be difficult. And ultimately, we want to be honest with these individuals. Adaptive athletes with learning disorders or cognitive disabilities may not be able to process questions normally or understand what we're doing without explanation. So mental illness may cause a personality or behavior change that impairs an adaptive athlete's ability to follow instructions. So we want to try to address the patient directly, even if their cognitive capacity is diminished. We want to gain the person's respect and attention. Specifically with this bullet point, with bullet point 2, try to address the patient directly, even if her cognitive capacity is diminished. Specifically with patients with like head injuries, with altered mental status, we don't want to talk badly about them in front of them. We don't want to talk down about them. There have been cases where patients are in an acute, like head injury type state, and then they recall, what rescuers said on scene. So pretty much the take home here is be professional at all times in terms of how you communicate and what you say around patients and what you say around family members. So we want to sit in front of and at the same level as intellectually disabled individual and maintain eye contact. First, we want to demonstrate what we need to do is a good way to establish communication and our intentions, and may relieve anxiety and build confidence in our care. Where did we learn about this? We already learned about this bullet point. Where did we learn about that?
Pediatrics with children?
Yes, absolutely. So pediatrics. So, making sure that the patient knows what's going on. We talk about what we're doing, and sometimes demonstrating or letting them play with the equipment before we actually move forward with treatment. So a good example is a stethoscope, right? Letting the individual play with the device, see it's harmless, and then moving forward with our treatment. We should expect that some athletes will have unpredictable reactions to treatments. So a patient with an intellectual disability, for example, may panic when wrapped in a waterproof tarp of a toboggan. So one of the most difficult situations could be strapping an intellectually impaired individual to a spine board during a load and go. Due to a critical injury, the explanation may need to be cut short, which can create severe anxiety for the patient. Although I would say that if we're truly in this load and go situation, probably most patients are not going to have the mental the mental wherewithal to really know what's going on. If we're in like a we need to go because they're that critical. So it may be difficult to establish whether a patient with intellectual impairment has a pre-existing condition versus a new injury. So an example would be expressive aphasia. So it's the inability to express speech normally. So we want to determine whether it's normal for the patient due to altered mental status or the result of a new injury. So we can ask the caregiver or caretaker, is this normal for the patient? This is a very common question that we want to establish when we have somebody with a intellectual disability is what is their baseline? So, we want to determine what is the individual's baseline. What are they normally? And this is a very common question we have to ask as EMTs and paramedics in the field when we respond to, let's say, a skilled nursing facility, or we have to respond to a patient who is long-term disabled. We want to find out what their normal mental status is like. So moving on to visually impaired or blind adaptive athletes, we want to greet them as we would any normal person. We want to reassure them that the scene is safe. We always want to ask their permission. Oops, skipped ahead, sorry. We always want to ask their permission before touching them, and we want to avoid having multiple rescuers touch them at the same time. We want to explain who is on the scene, so who is there. We want to make sure all patrollers are introduced or others who are on scene, what their role is, and what equipment may have been brought to the scene. If there are any distracting noises, we want to go ahead and try to explain the source of them. We want to speak directly to the blind person, not the person's guide. Remember, the patient is blind, not deaf, so they should not have any trouble understanding you. When inside, we want to verbally close the conversation by announcing if we're leaving the room, and we also want to explain who's in the room and what their role is and announce when others enter or leave the room. Remember, your voice substitutes for their eyes. So we want to make sure that we're explaining everything that is going on. So for hearing impaired individuals, depending on the severity of the hearing loss and age of onset, a hearing impaired person may not be able to communicate verbally. Few congenitally profound deaf individuals have fully intelligible speech. Individuals can read lips. However, consider if they're reading lips, whether or not you are wearing a mask. This can impact the person's ability to read lips. So when talking, you should always face the patient directly and remove any clothing covering your mouth. So please make sure you remove any masks. It is perfectly acceptable to write notes, passing a paper and pencil back and forth. This is a very good way to obtain sample information, especially medications. And another method is to text back and forth on smartphones. I will say, in today's technology-driven day and age, I like this way, texting back and forth or using a phone to communicate. As I can tell you, most people cannot read my handwriting, and I cannot read most other people's handwriting. So using a phone is a very good good technique. Or if they have somebody who knows sign language, have that person translate for the individual. You may need to talk to a deaf person or patient on the phone. You can call 711 for the relay system. So using any phone, you can access the service anytime. You will talk with an operator who will type your words for the display for the deaf person visual receiver on the other end of the call, and the deaf person will type back to the operator who will give you a voice response. Relay services may also be available communicating with American Sign Language by internet video conferencing service. I will say, I did not know about the 711 system. Out of curiosity, does anybody else know about the 711 system?
It was news to me too.
Yeah, I've here. You know what? Hang on. Let's try something. I'm gonna call my
So
phone.
do you have to have the other person's phone number, or you just keep handing the phone back and forth?
I don't know. I'm gonna dial 711. Put it on speakerphone. Let's find out what happens if I dial 711. Everybody game?
Let's do it.
Relay Nevada service operator 1011. May I have your calling, please?
Hi, operator 1011. My name is Sam. I'm calling from Ski Patrol. We're a class, and we're talking about the 711 system. I've got you on speakerphone, and we had no idea this existed, so we thought we would call in and see if it's truly a thing, which apparently it is.
It truly is.
So how, if you don't mind, do you have a second to talk about how the system works to my class?
Well, I don't have, I mean, I can tell you a little bit if you want the quick version. So say you want to reach somebody who's deaf or hard of hearing, you would dial 711, and then we would get the number from you, and we would call that person, and then everything you're saying would be typed to the caller, and they would read it on their screen, and then we would read back what they typed to you. And so on the other side of that would be if somebody is calling you, they would call 711 with their device, and then we would read what they're saying to you. And then sometimes the person can speak, but they can't hear, or sometimes the person can hear, but they can't speak. So all the variants we can process through here.
That's pretty cool. And are you guys staffed 24 hours a day?
Yep, it's a 24/7 thing.
Wow. And where are you guys based out of?
Well, we're across the country, so we're an essential service. We're federally required, FCC required. So.
Wow. Okay. Anybody from the class have any questions? I'm seeing a whole lot of head shaking. Thank you very much for your time.
Okay, yeah, if you ever need our services, just dial 711.
Awesome. Thank you.
Thank you.
Thank you. Bye. Okay. What did you guys think of that?
That's pretty cool.
So basically, if you dial
That's definitely nice to know.
Yeah, so if you dial 711 from a phone, sounds like they ask for the phone number, and there's a teletype system on the other line or on the other end where they can type into and get that information. When might you consider using that system?
It kind of seems like you would use that when you're on the phone, not necessarily like if you're kind of already there with someone, you could almost just type and text.
So you're right, Kelly. I guess what my question is in what situation might you find yourself having to use that system specifically?
Pick me. Can I answer, Sam?
Go ahead, Martha.
You have a juvenile and you need to speak with their parent, and one of them, either the juvenile or the parent, is hard of hearing or needs to use that service.
Thank you. That's exactly what I was going for. So you are in the ski patrol, so this would not be something that you would do on the slope. This would be something you would do in the first aid room. You've got a juvenile who came up with friends, and they tell you, hey, we need to touch base with mom or dad. And they say mom or dad is, can't hear. And then we could ask if they have a teletype or similar thing on the other end. And then we can go ahead and use the 711 service. All right. So moving into patient assessment. So patient assessment of adaptive athletes. So the evaluation of trauma or illness in adaptive athletes will present OEC technicians with unique challenges. What are some challenges that you might consider or things that you might think might be different or challenging when assessing an individual with or who's an adaptive athlete?
They may not be able to feel injuries.
So, Steve, that's a very good one. There is so my company, we do a lot of the medical standbys for the race car, or not race car, but the desert races. And there's a desert racer, I forgot his name. However, he's paralyzed from the waist down. And so he likes to joke around whenever he crashes and rescue gets there. He starts screaming, "Oh, my legs, I can't feel my legs." But he's normally paralyzed, and he always tries to get that new rescuer who comes up on scene. So if you can imagine being that new rescuer and you have, "Oh, I can't feel my legs, I can't feel my legs," and he normally can't feel his legs. He's paralyzed. Any other challenges?
They can't assist you to move. There are a lot of dead weight.
Yeah, absolutely. This is very common, at least in the field down here in Vegas, when we have disabled individuals. I mean, you're lifting pretty much a bag of rocks, sack of potatoes. I mean, oftentimes these individuals can be heavy. Any other challenges that you can think of?
I was thinking on the the athlete with that's paralyzed and can't feel his legs. What if they did have a leg break and they can't tell you?
Yeah, that's not just a leg break, but even a burn. I'm racking through my brain right now. There was a case that I recall. And I don't know why I recall this. I don't know if I treated the patient or if I heard about it in a case study or where, but the patient was paralyzed and somehow burned themselves. And I want to say that they burned themselves on a tailpipe. It may have been an adaptive athlete on a motorcycle. And I think they burned themselves on the tailpipe of the motorcycle and didn't realize it. So that would most definitely be a major challenge. So some basic concepts. So respect for the patient, patience, and common sense are an OEC technician's best tools for performing useful and accurate evaluation. Physical exam might require modification or special considerations for unique injuries. So principles of a good assessment, however, apply to all adaptive athletes, whether their disability is physical, intellectual, or sensory. So we always want to make sure we use appropriate BSI, as many athletes have bodily fluids and bags attached to their bodies. So after the scene is safe, we want to begin with a scene size up, followed by primary assessment and correction of significant bleeding and ABCD related problems. So here the D represents new disability. So we want to determine, is there something new that we didn't notice earlier? We also want to look for medical alert tags. And we always want to use latex-free disposable gloves and equipment. So we always want to start by introducing ourselves, telling them who we are. We want to speak directly to the adaptive athlete, not to their guide or companion, using his clear voice and calm demeanor. We don't want to assume that the patient knows your role and can read your name badge. We always want to ask if we can help. And I would take ask if we can help. How else do we want to rephrase this ask if you can help?
Ask if they want assistance.
I mean, that would be more like, can I help you? But how would you rephrase that question specifically to an adaptive athlete? So not can I help you, but something else.
Anything I can do for you?
Or how can
How
I
can I help you?
Yeah, or how can I help you, right? What is the best way for me to help you? Not, so we can ask them, hey, can I help you? And what is the best way for me to help you? We quickly want to reassure patients that the scene is safe and that we are there to help them. Remaining calm is essential. So if the adaptive athlete is unable to provide this information, we want to ask the athlete's guide or companion how we can help. We want to consider the level of stress that the injured ill or athlete is experiencing. And pain from an injury or anxiety can be caused by being separated from the companion or guide and may reduce their ability to communicate with you. So we always want to be a good listener. We want to use the responses of the adaptive athlete and the companion to guide our assessment and management. We want to refer to the person by name, not by condition. So don't say, hey, yo, go take vitals on that paralyzed dude over there. We always want to refer to them by name. We want to appreciate that you may not be familiar with the impairments or the equipment, but be willing to ask about their condition, about their equipment. And usually they're happy to help you. Over the years, I've had patients with all sorts of medical conditions, all sorts of problems. And, we are not expected to be experts on every single condition. And so when somebody, says something to me that I have never heard of, some rare disease that's probably that individual's gonna be named after, I usually, will follow up, tell me about it, tell me about your disease, tell me about your process, tell me about, this equipment that you have. And, my experience, and if anybody has any other experiences, please, by all means, chime in. But my experience has been that, if you ask them about it, they're more than happy to educate you about it so you know about it, in the future. Does anybody else have any experiences on that? All right, so moving on. So calling for additional assistance when starting an encounter with an adaptive athlete is often indicated. Remember, these individuals usually have more equipment, more resources, or more stuff that needs to be brought down. So we want to call for additional rescuers. What specifically might we want to call for equipment-wise if we have an adaptive athlete? What piece of equipment might we want to call for?
Wheelchair?
So let's say that we're on a ski slope and we have a adaptive athlete that is in a bucket ski that gets injured and now they need to be transported.
Scoop.
A second toboggan to transport the chair.
Absolutely, yeah, that's kind of what I was going with. Is maybe considering, not only how we're going to transport the patient, but how are we going to transport their equipment? And so we may need that second toboggan to transport their equipment down the mountain. So we can also call ahead and alert the first aid room that the patient's en route, which may allow notification of chaperones, staff interpreters, or family members who can assist in caring for the adaptive athlete. We want to make sure we obtain a sample history in OPQ or ST. We want to ask the patient's guide or companion about their baseline. So we want to find out, what is normal for this individual, right? Or if they're different, right? So let's say that they were that, that they're not normal right now, what question would we want to ask?
Maybe do they feel different?
So if they're not acting normal, we want to ask, when were they last seen normal? Right? And try to gauge how long it's been since they haven't been themselves.
Okay.
All right, so we want to make sure we do our full body exam. Using our DCAT BTLS, we're going to talk about what we're doing. We want to assess for abnormal blood pressure, muscle wasting, spasticity, loose joints, and skeletal deformities, which can all be pre-existing. Patients may have decreased sensitivity or no pain at injury site. So this would be an example of like your paralyzed individual that we talk about, right? Or they may not realize they have a broken bone. They may also have thermoregulation problems, so we want to watch for hypothermia, frostbite, or poor circulation in the limbs. There can be neuromuscular irregularities, such as hypertonia, or an abnormally high level of muscle tone, hypotonia, and rigidity, which can facilitate injury. Sit skier legs may be partially protected within the ski frame or in a fall or collision, but lower extremity injuries can happen due to osteoporotic nature of their leg bones. Osteoporosis is a condition where the bones weaken, in this case, by lack of exercise. Out of curiosity, did I ever talk about the girl that I had on the ski resort my first year as a patroller with osteoporosis or osteomyelitis? Did I ever tell that story? I remember my first year as a patroller, we had a 23-year-old girl that came up to the ski resort to learn how to ski. She was on Sherwood, or she was on Bluebird Chair 2, and she'd never been skiing before, and we got called to her because she broke her leg. And during the assessment, she told me she has osteomyelitis, and she's had 28 broken bones in her lifetime. And so she thought it was a good idea to go skiing. She went in for a hockey stop turn, ended up overcorrecting, falling, boot top fracture right here on her leg. And we were able to feel that false joint. So as we lifted her leg went in two different directions. I recommended to her that she try another sport such as crochet or knitting. A thorough physical exam is crucial. It's a crucial part to the assessment, but it should not outweigh the risk of prolonging the patient's exposure to hot or cold temperatures when outside. I would say this is more so not just adaptive athletes, but everybody, right? Like, you know, we want to get everybody out of the cold as quickly as possible. And then we want to get a complete set of vital signs, repeating at regular intervals. When they are talking about regular intervals, they're talking about stable versus unstable patients. So if we have a stable patient, how often should we be getting vital signs?
Every 10 minutes.
So 10 to 15 minutes. And how about an unstable patient?
5 minutes.
Yes, every 5 minutes. All right. We want to go ahead and assess the mechanism of injury, as the MOI can involve the patient's adaptive equipment. So a 3-track ski puts all the force and weight on the skier's one good leg. So we want to make sure that we check that knee for injury. Falls using tall outriggers or sit skis or short outriggers tend to cause more injuries to the upper extremities of sit skiers. And extremities can also be injured at the site of amputation by the pressure and twisting of a prosthetic limb. If there is pain or swelling at the site where the prosthetic attaches, we want to check for trauma. Unless there's bleeding, we want to wait to remove the prosthesis. We only want to remove it in the aid room and never without asking permission. We want to treat these carefully as they are custom and can be very expensive. I hope you guys are seeing a trend. I think we've talked about this at least a dozen times already, that these pieces of equipment are very expensive. And so we want to make sure that they remain with the patient and that we treat these with absolute respect. If the equipment does become removed by the fall, we want to transport in a toboggan, with the patient, or depending on the equipment, we may need to call for an additional toboggan or additional resource such as a snowmobile to transport the equipment down the mountain. Ostomy bags and tubing should be examined for damage and associated bleeding from the stoma site. The adhesive tape used to securing the bag to the stoma site can be pulled loose. Tubing can become blocked during extrication or when packaging a patient for transport. So we don't want to put any pressure on an ostomy bag or bladder bag while securing the patient. And we always want to observe standard precautions when inspecting or handling an ostomy or a collection bag. Abnormal communication, emotions, and movements may be part of the patient's pre-existing condition. So we want to ask the patient's caregivers or companions what is considered normal functioning for the athlete. As you can see here, I mean, this is another repeating theme, okay? I think if there's two things you take away from today, keep equipment with patients, find out what their baseline is, and I'd probably say third or 2.5 is how long have they been like that, or like if they're not acting normal. So if not available, assume that any deficit mental status can be a result of a new injury or illness, and that an established intellectual disability may mask an emergent condition. I will say probably in most long-term care patients, somebody is usually there who is able to tell you, what their baseline, what their mental status is like. So treating Down syndrome patients can be deceiving. They may have a serious injury that can be overlooked. Typically, Down syndrome patients are calm and easygoing and tend to minimize pain or complaints. And there may be associated psychological abnormalities. There may be associated physiological abnormalities. Loose ligaments in the upper cervical spine or joint instability. So a thorough exam is very, very important. So adaptive athletes with autism spectrum disorder also tend to minimize complaints of pain. So ASD is a disability of communication. So these patients may appear to ignore questions or repeat what has been said. They may avoid eye contact or attempt to move away from you. So you want to use simple, concrete phrases that can help direct the assessment. So let's talk about managing these individuals, shall we? So most medical or trauma problems are treated the same as other patients. So splinting may require adaptation, and certain pre-existing problems may need to be addressed. If time permits, it may be medically necessary to demonstrate how to put on a splint or another patroller before putting it on the patient. So in managing adaptive athletes' injuries, how we communicate is key. We may have to modify splints. We may have to modify, how we place these patients in splints or on backboards. So stabilization of injuries in amputees often means splinting in the position of comfort. And I wouldn't say just in amputees, but really any patient we're going to splint in the position of comfort. We want to modify splints and strapping if needed, but never force an injured extremity into a rigid splint. Examples of modified splinting techniques based on impairment. So we want to use traction for a mid-shaft femur fracture in a below-the-knee amputee is not practical in outdoor environments. We want to mobilize this fracture above and below the fracture site using a quick splint. We can use extra padding to avoid pressure on areas without sensation, whether those areas are close to the injury or not. For patients with muscle spasticity, as in cerebral palsy, traction splints used for a femur fracture may aggravate the spasticity. So we want to use a quick splint or other mobilization technique if necessary. So specifically talking about spinal cord injuries, so a paraplegic has no use of their legs. So that would be their lower extremities or two extremities, hence the para part, whereas a quadriplegic loses a function in all four extremities. So in patients with pre-existing spinal cord problems, we want to be alert for the potential causes of autonomic dysreflexia. This can be a true medical emergency. So simply unblocking obstructed catheter or loosening obstructed clothing may prevent or relieve the autonomic dysreflexia. An injury below the level of the previous spinal cord may cause autonomic dysreflexia. Spinal cord injury patients can assist you in determining the cause. Patients can tell you their normal blood pressure or pulse rate. And normal blood pressure in somebody with a spinal cord injury typically ranges from 90 to 110 millimeters at mercury. So many syndromes or traumas causing cognitive impairment can also include other neurological conditions. So we want to be prepared to treat procedures if necessary. Disabilities from stroke or traumatic brain injury can often cause specific motor and or sensory deficits. So signs such as muscle wasting or the weakening or shrinking of muscles or loss of muscle mass or flexor tendon contractures, which can cause permanent contortion of a muscle or of a joint or limb, may be evident in patients with pre-existing brain injuries. And this can make your assessment much more difficult. In what ways can a contracted patient make your assessment much more difficult? In what ways can somebody with contractions or somebody who's like, you know, kind of contracted like so, how can that make your exam difficult? So first of all, think about it, right? If we have to get a blood pressure on somebody and they're contracted, how are we going to be able to get a blood pressure, right? Also, too, if they've got muscle wasting or if they've got atrophy of the muscles, you know, trying to get a blood pressure, you know, we have to make sure we use the right size blood pressure cuff. So in an adult victim, you know, if you grab an adult blood pressure cuff for somebody who has severe atrophy of their muscles, you know, you're not, you know, you're going to get a false blood pressure. Maybe also difficult to get pulses on the individual. Anybody else got any thoughts?
They're
It
going to
might
be
be
really hard to
hard.
split.
I think Kurt was speaking first. Kurt, you want to go ahead?
It might be hard to assess joint issues because if they're contracting, you know, you need them to kind of relax to be able to test joint movement.
Absolutely. And Dean, were you going to say something?
I said you're going to have a hard time trying to splint them.
Oh, 100%. Yeah. You know, if they're contracted and they've got a broken bone, yeah, major issues with splitting. So getting a physically, or moving on, talk about removing equipment. So getting a physically disabled athlete out of their specialized equipment and caring for the injury requires gentle care, planning, coordination, common sense, and a lot of help and ingenuity. So we want to evaluate the situation and do what is easiest and safest for the patient. Injured adaptive skiers need to have their adaptive equipment removed. So we never want to attempt to assist an injured patient down the hill in the patient's sit ski or ski stander. We never want to keep an injured patient in their sit ski when placing into a toboggan or litter. So we want to ask the adaptive athlete or their guide how the various straps and buckles work, or how their equipment operates. And you know, not so much. Actually, let me rephrase that. This not only applies to asking how the equipment operates to disabled athletes, but even just anybody that we treat. You know, you may come across ski equipment that you are not familiar with. You know, by if you guys want to use the chat feature, by raise of hands, or if you guys want to turn your cameras on by raise of hands. Does anybody know how or telemark equipment works? Right, that would be a piece of equipment that you may not be very familiar with. You may not see a whole lot of it. And so you may need to ask the patient, how do you, work your telemark equipment? Simply asking how equipment, operates. Don't be afraid to ask, even if it's somebody that is not developmentally disabled or somebody who is not physiologically disabled. Normal people, they have equipment you're not familiar with. For example, like snowboarders, right? There's a binding system called the flow binding, right? And you may need to get somebody out of that. Once again, don't be afraid to ask, how that equipment works, whether or not they're disabled or not. Always ask, how does your equipment work? When removing a skier, or when we're removing a sit skier from their ski, make sure all straps have been unbuckled and loosened. So getting a physically disabled athlete out of their, I think we went back in time, sorry. So management and transport. So sit skiers with spinal cord injury, spinal bifida, and other neurological disorders may have high pain tolerance. Also, serious injuries may be below the level of the spinal cord column. A thorough patient assessment is mandatory before moving these patients. So based on the MOI, we want to make sure we check for deformity, swelling, and bleeding before moving. Osteoporosis in these patients can sometimes lead to fractures and dislocations from relatively minor falls or collisions, which we learned about this earlier, right? Very simple fall for my 23-year-old girl that broke her leg. So we want to be sure to fully support these patients when transferring. We'll need extra patrollers to help move, since some of these patients can be stiff or floppy, or like somebody said earlier, many of these patients are simply dead weight. So we want to make sure that, you know, we are lifting them appropriately. What is a piece of equipment that we can utilize in order to assist with lifting these individuals?
Scoop.
Scoop is good. What else?
We have the half spine board.
Are you talking about the KED device? Or a half wooden spine board?
Yeah, it's a half of a spine board.
No, I really wouldn't. I'm not really a big fan of those. You know, those are really good for seated patients. And they really don't have good handles, especially down at like the foot end, to be able to grab onto. Especially if you have somebody who's like that dead weight. Not really a big fan of the half spine boards.
Hey,
But
man,
yeah.
I like the idea of using a KED, maybe not because it's a spinal injury, but it gives you a nice way to secure the patient and lift. That was a pretty
It does.
idea.
But the concern you got to remember with the KED, though, is that you have nothing on the legs. So if you do have somebody with very floppy legs and you lift them up, or somebody who has no muscle on their legs, with a half backward or a KED, if you lift them up, you know, now you've got to maintain control of those legs somehow. But definitely a backboard is a good piece of equipment. But, you know, what comes in all of our toboggans is a tarp. So, you know, you may have to roll them onto a tarp to be able to lift them up. And then also, too, something that was purchased this year, or maybe last year, they're new to us, are the mega movers. Does anybody know what a mega mover is? So a mega mover is a piece of canvas with handles, and there's usually 4 handles on each side. And so basically you would roll this patient onto the mega mover, and now you have handles that you can lift the patient with. Mega movers can lift patients upwards of almost 800 pounds. So very durable piece of equipment. All right, I think we've hit the second bullet point pretty hard, how expensive equipment is, so make sure it remains with the patient, and make sure their equipment is available to them when they get to our first aid room or our clinic. So we really haven't talked much about service animals. In fact, I haven't talked at all about service animals, but many adaptive athletes may have service animals in the base area, so we want to maintain the normal relationship between their animals and the athlete. And a service dog is not a pet, so we want to make sure the animals are not petted or distracted by bystanders in the aid room. Cognitively impaired individuals, when lifting, transferring, transporting a cognitively impaired adaptive athlete, we want to make sure that we show them in advance the steps that will be taken and the equipment used. We want to explain the roles, explain the procedure, explain the need for restraints and securely placed in the toboggan for transport, and demonstrate how the restraints work in advance. With a visually and hearing impaired individual, for transporting a visually impaired individual, basically we want to talk them through what we're doing, right? So we want to explain exactly what we're doing to the individual. If a blind person is mobile and needs to be guided while walking, we want to offer our arm and allow them to walk alongside us. We may need to come to a complete stop before steps, curbs, and other objects. When lifting, transferring, or transporting a hearing impaired athlete, we want to show them in advance what we're going to do and the equipment that will be utilized. For lift evacuation, this can be a problem trying to get a individual off of the chairlift if they are disabled. So every time an adaptive athlete in a sit ski gets on a chairlift, a safety strap should be attached to the back of the chair. The strap is necessary because the safety bar may not fully close due to the size of the sit ski or the sit ski's bucket. So adaptive athletes should always be given priority when evacuating patients or evacuating chairlifts. Athletes with mobility problems have an increased risk of cold exposure. Athletes with intellectual disabilities may have disability or difficulty tolerating chairlift evacuation delays. And so evacuating early is a standard practice. Sit skis typically have factory built attachments to an evacuation line. So just to recap this, so if you do have, as part of our lift, lift evacuation process, usually what we do is we have a patroller ski the line, and the purpose of skiing the line is to identify anybody who may need to be priority being taken off the lift. So we touch base with everybody on the lift, figure out who our priority patients are, and then those individuals get off the lift first. And then with sit skis and many adopted patients, they actually have a harness in them, so if they do have to be taken off, they can quickly be attached to our rope system and pulled off of the ski lift. So before riding a lift, adaptive athletes should inspect all webbing on their bi-ski or mono-ski to make sure it's operational, know how their straps work, and carry a properly rated locking carabiner to secure their evacuation straps to our evacuation equipment. Evacuation straps are generally placed between the patient's legs and on either side of the bucket. And each ski area must develop our own plan for evacuating skiers from all non-surface ski lifts. I believe our plan is if they are with somebody that guide or that person assist them with getting that adaptive athlete off first. However, we do have an adaptive athlete or somebody who cannot come down, then we do have a way to get a patroller up to them. Usually that involves choosing the lightest patroller that we have and then having a bunch of strong, muscly individuals pull a rope up to get that individual up to the ski lift. Blind athletes or those who have cognitive impairments will need additional oral coaching and reassurance during evacuation, even if they have a guide with them in the same chair. The evacuation process may be difficult to understand and can cause anxiety. It's important to clearly demonstrate all the steps that we are taking. So we always want to have a cognitively impaired skier or rider before the person's companion. We want to have someone remain with the adaptive athlete and talk so they feel safe until their companion is evacuated. If 3 or more individuals on a lift, it may be helpful to evacuate one of them first so the person knows exactly what is going on. Hearing impaired skiers and snowboarders may not be able to hear verbal directions, so they may be riding or skiing with a friend who can act as a translator. We may need to communicate with them using a cell phone, using text on our phone. However, what specifically is the issue with our ski area and texting the patient?
No service.
Absolutely, we have no cell service. So we want to clearly visually demonstrate how the evacuation process works. And once again, if there's 3 or more people on the lift, we want to take somebody off first so they see exactly what to do. All right, so that brings us to the conclusion of adaptive athletes. Does anybody have any questions regarding adaptive athletes? All right, so I believe Patty is on the line. She's going to get set up for getting into behavioral emergencies. And I say we go ahead. It is almost 7:24. Let's take a break. Let's come back at 7.
I'm here.
Who's I am?
Oh, sorry. It's Arzu.
Hey, did you leave anything in my car?
I don't think so.
Okay.
Did you find something in the car?
Yes.
Uh-oh. I don't know. It could be Lindy's.
Oh, okay. You'll let me know when you are missing it.
Is it mine?
Some gloves?
Uh-oh. Yeah, it could be mine. Actually, now that you say that, I think they are mine.
I'm sure they are.
Okay.
I'll take them up the mountain tomorrow.
Okay, thank you. Yeah, my locker is unlocked, so if you don't mind tossing it in there or just put it somewhere, it doesn't really matter.
Okay, no problem. Your name, it has your name on it?
The locker does, yeah.
Okay, that's where I'll put it. Okay, it's 7:35. Where is everyone?
I think he said 7:40.
Oh, did he?
I'm not, I believe that's what he said.
Oh, good. Did you get something to eat?
I did, yes. Did
Thank
you?
Oh, yes.
I like scarfed down as much food as I could.
That's all you can do. Hello, Len. Len, you survived?
Talk about being tired.
Tuesday.
Yes.
Actually got 6:10.
See, I'm preparing you for tomorrow.
Oh boy. Good luck tomorrow.
He's gonna have his kids with him.
Hey, how's the traffic up on the hill? I've been stuck down here just below you guys, but
It's busy.
it's busy.
It's busy. It seemed like everyone has left their Adobe and decided to come out and play. Fresh snow. And it's
Are
supposed
is there lift lines to speak of?
Oh, yes.
Yes, okay.
They weren't that, I went today and they weren't that bad.
And
Okay.
you didn't look us up?
What?
And you didn't stop to say hello?
Well, I thought about it, but I didn't know exactly where you would be. I mean, were you in the far room?
They're
No.
the people with the red jackets on.
No, and I didn't see you because I did see one guy in a red jacket, and I thought about asking him if you were there and where you were, but I didn't.
Okay, so what were you wearing?
What was I wearing?
Yeah, were you skiing?
I was. I was
What?
skiing in my bikini.
Oh, I didn't see you.
I'm just kidding. I'm just kidding.
I
Hey,
actually did see
what
some-
happened with the parking situation?
Oh, that's why I ended up going up today instead of yesterday. I just had to make sure that if you go on their website, they just really stress that you purchase a parking pass, or if you have a ski pass or whatever, you just have to make a reservation before you get a ticket or a pass for the day. So I just went today instead.
Okay.
There was plenty of parking though.
Did you ski Sherwood or you both? I mean, Bluebird.
I did all of them.
Okay,
There's only 2 runs open. I don't know the names of all of them, but
so what were you wearing?
I was wearing a light gray, whitish North Face coat and black pants and skis. The white helmet.
On?
What?
You had a helmet?
Yes.
Didn't see you.
I didn't see you either. Otherwise, I would have said something.
Anytime that you come up, you have to come and talk to us.
Well, where would I find you? Because I'm going to get
Ask
this Wednesday.
the lifties.
Where?
Ask the lifties.
Oh, okay.
Or just go to Base Medical, which is right next to Chair 2, which is Bluebird. There's a little medical shack in there. It's called Base Medical. We have a cross on the outside. And
Are
it's-
you,
Yes.
Patty, you have staffing there's usually someone at the top of the lift, correct? There's
Yes.
always a patrol shack.
Yes.
Not always will there be someone there, but essentially there's enough staffing to keep someone there unless there's multiple calls at once.
Right. Which there was.
Yeah, I'm sure there was, yeah.
But yes, all you have to do is ask. You'll find
Okay.
it.
I saw dogs there too. There was 2 dogs.
Right? You saw Eli's dogs. Those are Eli's.
Okay, is he the ski patrol?
He's a ski patroller.
Okay.
Where did you see the dogs? Were they on top of 2? Top of Bluebird?
Yes.
Okay, yeah, they kept us company in the shack up there all day today.
Oh, lucky. How
Yeah.
awesome.
So did you have a good time?
I had a great time.
That's all that counts.
Yeah, it's great. It was great. I was so happy to be skiing.
See, that's what everyone was thinking today.
I heard it was worse yesterday.
I don't know. I
Yeah, it
wasn't
was
there
not.
yesterday. I heard it was mellow yesterday and chaos today.
Oh,
It was not worse yesterday, no.
Yesterday was uneventful.
I mean, we had some things going on yesterday, but nothing in comparison today.
Oh, okay.
It's the moon.
Why don't you, oh, I'm sorry. You ready to go? 'Cause I was gonna
No,
say,
go ahead.
tell us what kind of injuries or illnesses you had today.
Oh my gosh. Well, I can tell you the couple that I had was a snowboarder, first time snowboarding, no lessons, halfway down Rabbit, left knee injury, and then later in the day I had a gentleman who had a snowboarder decided to, I don't know, show off to his girlfriend or something, hit a rock and got a pretty good laceration on his left leg. It was, I was bleeding a considerable amount.
Was
Well-
the laceration from his board or from the rock?
He says it was from the rock.
Because it
But-
becomes hard to a snowboarder cut their own leg.
Yeah.
But you know, it all kicked off with the person getting stuck in the elevator.
Oh, awesome. That's really good.
Well, let's say it was an eventful day.
Mhm. Oh, cool.
Okay, you ready? Are we all here? Is it 7:40? Oh, there's Dean. He's back.
I'm back. I had to feed my face.
Hey, we all have to do that. It's been crazy. Okay, so Kurt is there, Abigail. All right, so let's start. Can you see my screen?
Yes.
Thank goodness. Not me, but my screen, right?
Yes.
Okay, good. So we're going to go into behavioral emergencies and crisis response. Did anyone read this chapter? Don't, jump all at once. I love it. Okay, so this is going to be fun for all of us. So what do you think behavioral emergencies and crisis response means? Anyone want to jump in? How about Kelly?
Same as pediatrics.
Yeah, I was just gonna say, I deal with a lot of this stuff at school. You have, your chemically imbalanced people, your anxiety, depression, mood disorders, things like that.
Okay. Anyone else want to attribute to that? No?
Also be belligerent, intoxicated people.
Okay. So we'll go further and see if that's what it is. And do we have a lot of intoxicated people up there?
Oh yeah.
Oh yeah.
What is that word, ETOH?
Only in the afternoon.
Usually that's about when it starts, 12 o'clock.
You start finding cans at 9:01 in the morning.
People
Okay,
throw a cold one before they leave the parking lot.
all right.
Cans and other paraphernalia, shall we say.
Let's say they leave us presents at the end of the day. Okay, so define the terms behavioral emergencies. You're going to describe the main differences between mood adjustments and affective disorders and psychotic disorders. You're going to list the signs and symptoms of common behavioral emergencies and identify and maintain rescue safety. Of course, safety is always a concern when you have people that are on the other side. So demonstrate how to assess a patient, demonstrate on the treatment of a patient, define when to restrain the patient. Now that is something to think about. Restrain them on a toboggan, restrain them on a backboard. Do we put zip ties in the back and put their hands in the back? Who knows? We'll find out. Demonstrate how to properly restrain a patient. Okay, a critical incident stress briefing. That's going to be easy. These are all the words that you should know and what they are. I won't go into that because we're going to go into it in the chapter. Chapter overview. Okay. OEC Tech, you may encounter people who are in crisis, unexpected, unusual, or possibly a dangerous manner. So maybe, let me read this a little bit so I can shorten it. Okay, so let's say when you look at this photo, what do you see there? What is the first thing that sort of wakes you up?
His contribution.
Is his fist. So when someone has his fist up in the air, about to the level of your mouth, what would you do?
Back away.
Back away. That's a good thing. Back away. You're too close. You're in his space. Because if you stay in that position, guaranteed either he'll use it and you don't want to agitate him anymore. Now, we don't know why he has his fist in the air. We're going to find out. So, back away. And what is our main concern for us?
Our safety.
Safety. Safety. If the scene is not safe, we back off. We call for extra resources. Is that true?
Yes.
Yep.
Because you don't want to be put in a situation where you have to deal with a guest in this manner. Okay. Behavior. Acts or conducts oneself, especially toward others. Environmental relationships and internal feelings contribute to behavior. You don't know what happened to that person before he got to the mountain. You don't know, did he wake up that way? Is he that way normally? What set him off? Some behaviors come from underlying emotions, such as laughing, crying, and yelling. So you're dealing with a person that has issues, and what you have to do is sort of keep those issues at a minimal. You don't want to aggravate, escalate, and create a situation where you are in danger. Let me see. If severe enough, the person is experiencing behavioral emergencies. So behavioral emergencies is a situation a person acts in a way is unacceptable or intolerable to others. Let's see. Others see the behavioral emergencies, but the person does not realize it. It's true. Some people, for whatever reason, they talk loud. They use every foul word in their vocabulary. Is that normal for them? Maybe it is. Maybe it's not. So hopefully that when you have a person in that situation, that you can control the situation before it gets out of hand. But if not, always call for extra resources. And OEC Tech, you must carefully approach a patient who exhibits abnormal behavior. Of course, always. You're always looking at the person. Don't jump in. Evaluate before you go any further, and then enter. It's like you have a space, and do you go further or do you stay there and you think about it? So do they have a medical disorder? Do they have a chemical disorder? So describe a medical disorder to me. Anyone?
They're off their meds.
I'm sorry, what?
If they didn't take their medications, or it could be diabetes, something like that.
Okay. All right. How about bipolar? Oh, that's the fourth one. Forgive me. Chemical disorder. What would you call a chemical disorder?
Intoxicated.
Intoxicated, drugs, even though some of the drugs are legal now. Traumatic disorder. Give me a traumatic disorder.
They hit their head and just not feeling right.
Right. We don't know. And a psychiatric disorder. What would you say? Bipolar? Schizophrenic?
Sure.
Okay. The important thing to do is recognize it, that it exists. Safeguarding the patient and others, and address any threats to life. So I think we do that every day in life. Stress is a big one. It creates a lot of problems.
Good question.
What?
How often are we looking towards like the other people in a group when we have an injured skier, as far as like stress and behavioral conditions and all that? Like, how often does it happen when like boyfriend, girlfriend, spouse, whatever, father, son, that's with the injured person has a breakdown or whatever?
Are you asking the question, or are you stating?
I'm asking that, yeah. Like, how often does it happen when it's not the actual injured person that we're treating, but somebody in their group breaks down?
It happens a lot. It really does. Because what happens sometimes, someone gets injured, and let's say there's 4 people in the group. The person that is injured, well, maybe the other person in the group gets all upset, starts cussing, wants to start a fight, and before you know it, it escalates, and it becomes a fight. It's become yelling, screaming, they're pissed off, maybe they had too much to drink, and you don't know that until you enter that little circle of what's going on. Is that what you're saying? Does that make sense?
Kind of, yeah.
Well,
But I was thinking like somebody else's injury brings, another person in the group to their breaking point.
right. Here they're having a good time. All of a sudden, someone cuts someone off, and that guy gets hurt. Now his friend is hurt, and now he's upset, and he may have to go home, and he's pissed off, and it just ruins his parade. And people, they get tired. They're agitated for whatever reason. They're agitated, and some people can't deal with it. Maybe by skiing or snowboarding, it relieves stress, but sometimes it creates havoc because the macho part of someone comes out. We had a situation where this snowboarder was looking at this girl, and her boyfriend was there, and before you know it, they started yelling at this snowboarder, and it was a full-blown fight. And it was like, what's going on? I mean, can't you have a good time? It's snowing, the mountain is great, and you want to fight? Stop. So stress from work, stress from a relationship can cause a lot of strain on a person. And you would think by going up there, you relieve your stress. Sometimes it's not so. The source of a person's apparent behavioral emergencies may be traced to an underlying medical condition. That is always so. You detect an altercation, an alternate, say the word, in mental state. Oh, when they're altered, when their mental status is altered, always consider potential medical conditions first. Anytime that someone has altered mental status, it could be from what? Alcohol, right?
Yes.
Yeah,
Lack of oxygen, right?
sure.
If they're diabetic, It could be they're hypoglycemic, right? It could be drugs of any type. Maybe they didn't take their medication. Other possibilities of medical causes. Epilepsy and seizures, I always thought they ran together. How about cardiopulmonary disorders? What do you think that word is? Cardio. What does cardio mean?
Heart.
Heart. What does pulmonary mean?
Lungs.
What?
Lungs, respiratory.
Lungs. So heart and lungs, it's a disorder. So they work together. How about hypotension? What does that mean?
Slow.
Low blood pressure?
Yes.
Okay. How about dehydration? Tell me what it means.
Not enough water.
Right, not enough fluids to feed the body, to feed the brain, to feed the gut. So electrolyte imbalances, that could do it. Medication overdoses. Does that sound familiar?
Yeah.
Anyone on the mountain last week when we had an overdose?
Ooh.
Yes or no?
Yes, I was there.
I was
Okay, so say you're thinking, gee, it's a beautiful day, the snow is falling, you're out having a good time. Now, why would anyone overdose, right? But it does happen. So you have to recognize it and figure out what you have to do to get to deal with it. Illegal drug overdose? What could that possibly be?
Cocaine, opiates.
Okay, right. Taking too much, mixing it with alcohol is the worst. So now you're speedballing it, and you got a downer and an upper. But you see it all the time, and you smell it all the time. All the time you're skiing or snowboarding, you can just smell it. It's in the air, and it's not the ferns. Head trauma, would that cause a person to be altered?
Yes.
Okay. How about carbon monoxide poisoning? Where would you see that?
Bluebird Shack.
That is true. That is very, very true. So we always keep our windows open, do we not?
Yes.
Right, very careful.
Do you guys, the
What?
shack's not, I thought the shack went to electric heat.
Well, it does when the power works.
Copy.
Okay. The use of mind-altering substances. We've already talked about alcohol and drugs cause both altered mental status. Some people get really happy. Some people get defensive, get agitated, or even get violent. So you just don't know. People metabolize certain things in certain ways. You just don't know. So you have to learn how to deal with it. Individuals who abuse can be depressed or agitated or even violent, which we did talk about it. And then there are those plants. Wild plants, berries, and mushrooms can also produce adverse effects. Like what kind of adverse effects? Tell me. I've never heard of wild plants causing that. Opium? Peyote?
Peyote.
Peyote. Oh, that's right. They would tell stories. And there
Magic
would be
mushrooms.
spirits in the sky, right? And mushrooms. You know, they're legalizing that. in the medical part of it. Aren't they called magical mushrooms?
Yeah.
Yeah.
Hey, something that grows on the just by the road around here is morning glory.
Is that good or bad?
No, I'm trying to remember Sacred Datura, I think it's called. But yeah, a lot of people eat it, and they think it's a religious experience.
Are you
So-
serious?
No, I'm serious. I'm very, very serious. I've had that emergency before. Not
Ooh.
not on the ski hill. Like, yeah, I came up here eating the morning glory, but it is definitely something out there that whatever causes that stuff.
Oh, gee, we should package it. Okay, so what do you see in this photo right here? What do you think's going on?
The fight.
Fight? Agitated? Person's trying to hold him back?
Alcohol induced.
Oh, do you see that? Do you see those glasses, how tall they are? I wonder if this is a club or a private home. It looks like a club. Okay. Let's see. Traumatic brain injuries can cause altered responsiveness and behavioral disorders. Let me see. Patients with head injuries can present with confusion. That's true. You don't know. That's why if he's with a buddy or she's with someone, is this how this person normally acts? So that's information that you want to gather as you're treating this person. Is this normal behavior? So that would be up to the patroller to get that information. So this way, you know how to treat a person. They can get agitated, confused, verbal outbursts, personality changes. My personality changes every day. So, but I don't think I have a head injury. The brain, hypoxia. What does hypoxia mean?
Low oxygen.
Right, low oxygen. From what? What's hypovolemic shock mean?
Fluid loss.
Okay. Hypo? What does hypo mean?
Low.
Low, exactly. Environmental conditions including hypothermia. What is the word hypothermia?
Low body temperature.
Right. Hyperthermia.
High body temperature.
Right. So do you think that this would change a person's behavior?
Absolutely.
Okay. A mood adjustment or affective disorder is characterized by the abnormal, let me see what this word is because I've got it covered up. Behavior in persons who remain firmly in touch with reality. Anxiety, depression, paranoia, agitated, bipolar. Okay. Sharply contrast with psychosis. Let's see, often have visual, oh yeah, right. So, I don't know if anyone's familiar. Have you ever seen someone just stand there and talk to themselves and you think they're on their phone and they're not?
Yes.
And they do their hands in a certain way. And if you watch them for a period of time, it's rather interesting how one could have a conversation with someone that's not there. But maybe they are there to them, but not to you. Okay. People with these common seeing conditions understand what is real. And yeah, that's true. Anxiety. Tell me about anxiety. I know you can read it, but tell me a little bit about anxiety. Anyone get any anxiety at all? Have you ever experienced that feeling?
Butterflies in your stomach.
Butterflies in your stomach. So what else? What happens to your heart?
It races.
It races. What happens to
Sometimes people have panic attacks too, right? From it.
exactly. Tell me about what else. You think they're diaphoretic? Do you think that they get anxious? Tell me.
Sweating and nervous and
And it's hard to calm people down that are that way, but it's real to them. For whatever reason, it triggered. And it takes a while to calm that person down. So have patience. Don't say things, oh, you're not acting, it's not appropriate, what's wrong with you, everything is okay. It's not okay for them. So talk in a soft voice, see if you can get them to focus on something else. And it's just, it's like a panic attack. They have to control it. It goes in and out. Something sets it off. So your voice, when you approach a person like this, just pay attention. Let them talk to you. If they don't want to talk to you, just watch. Just sort of observe so that you can decide how you're going to treat that person. Let me see. They get feelings of impending doom, inability to function. Some do. Some can't move. Some have to take medications for it too. Shortness of breath, chest pain, a sense of impending doom. You will get tingling finger in their hands, that tingling sensation. But it's real to them. But ask them, do they suffer or have they ever been diagnosed with anxiety? And what triggered it? Some people know, some people don't. Some, you get someone that's been on the ski slope, they go on the lift and they don't like heights. Maybe that would trigger it. Maybe they get to the top, they look down and oh my gosh, they break out in a cold sweat, they start to cry uncontrollably. So you have to figure out how to cope with this, how to deal with this, because you're the patroller that's going to respond to it, and you have to have sympathy. You have to have patience and understanding. Depression. Depression's true. It's real. We used to laugh about it. How could you be depressed? Life is too crazy to be depressed. But it's a true feeling. It's a feeling of sadness, worthlessness, hopelessness, and despair. And I think this pandemic that we're going through, many people have suffered considerably with depression. Some people take medications for it, some don't. Some sit quietly and don't express how they feel, but they are depressed. Do any one of you know someone that's depressed or have met someone that's depressed? I mean, we're talking true depression. Kimberly?
No, I don't know anybody that's got depression.
Okay. Martha?
Yes, I definitely have close interaction with people with depression, bipolar, schizophrenia, not so much many people on the anxiety spectrum. But yeah, come over to my house. It's all crazy over here.
So,
gotcha.
So how does that make you feel when you encounter this?
I'm sorry, are you asking me?
Yes.
I'm sorry, what was the question?
How does this make you feel when you encounter this?
Well, I'm not clinically depressed, darling, but people with depression, I mean, what we would see really, you know what, depression doesn't really strike a big EMS chord with me. It's more of the mood swings, anxiety. Right. What's what's really important about anxiety is that when you get injured or you're having a sudden illness, whether or not you have clinical anxiety, some of the symptoms are it's an anxious reaction. So that's what's always difficult for me in, a few slides ago, is really kind of, figuring out, is this person having a medical illness? Is this person having, showing signs of shock because of a trauma, and that's anxiety? Or is this person having anxiety because that's what they're being treated for, and that's a condition that they live with?
Mhm.
On depression, it's more of people not getting out of their home, getting out to ski, and then that leads into some instabilities where hurting themselves or hurting others becomes some of our concerns.
Right, right. So it's how you approach the situation to deal with people that are in this state. So it's real to them, remember that. Paranoia. Paranoia is, I never realized what paranoia was until I had run on a couple of patients. And it's real, they're delusional, eccentric behavior. They don't trust anyone. A lot of them won't look at you directly, eye to eye. They always turn their head, put their head down, and they're always cautious of what they say. They don't want to get too close. They're afraid you're going to do something to them. So that you may encounter people like this and you may not, but it's real. That's why some of them take meds and some of them don't. That's why you have to find out your history and their medical condition. And some of the people that are paranoia take medications, but they go off of them because they don't like the way they feel when they take it. So they go off of them, they think they're okay, and they're back in the same, they're chasing the rabbit. So agitation, we already did that. Let's see. Bipolar disorder is the same basic thing. It's diagnosed, and it's a mixture of manic. They have the manic phase, the emotional highs and the lows, increased excitability, increased energy levels for activity, elevated moods, restlessness, or impulsive behavior. Some will sleep, and some will stay up for days and days and don't sleep. So there's many emotions that contribute to this. That's why they call it bipolar. Psychotic disorders. Psychotic individuals can experience anxiety, depression, paranoia, or agitation. Do not understand the difference between what is real and not real, which we already went through that. Schizophrenic is a complex mental disorder. A person cannot differentiate between what is real and what is not. Yeah, impaired reasoning, emotional instability, paranoia, visual hallucinations, delusional, and violent behaviors in some cases, not all cases. So what can you do for it? Not anything as a provider, except keep them calm and see if they have been diagnosed with it, because they are acting not normal. And if they are schizophrenic, are you taking your meds? When's the last time you took your meds? It's a lifelong mental disorder that may cause that can be effectively managed with medication, provided the person continues to take it. But like I said before, they take it, they don't like the way it feels, so they discontinue it. So they relapse. Some use alcohol, marijuana, and drugs, and exposure to emotional trauma and loss. Okay, suicide. Suicide, that is the intentional taking of one's life. It's a problem that affects thousands of individuals. Suicidal gesture. Superficial wounds on the body. Yeah, have taken pills and then immediately told someone. So the superficial wounds on the body, Kelly, you're a teacher, right?
Yes.
And what grade what is the age of the students?
So I work with elementary students. So I work anywhere from kindergartners to fifth graders.
Okay. Have you ever encountered anyone it's called cutting?
I have not, but I've heard about it happening in our school. But I have not personally had an encounter with it.
Right. I didn't realize that existed.
Especially with such young children.
Yes.
Yeah.
When we transported this one person that she had all these little cut marks on her arm. I didn't know what it was until someone told me, but it's mutilation, really. It's sad. And why would somebody take pills and then immediately told someone? If you're going to commit suicide, don't you think that you would just take the pills?
They want attention.
Cry for help.
Yeah, it is. And it's real, Hopefully they don't do it again and they get the right treatment. They see someone and hopefully it could put them on the path of straight and narrow. Let's see. The patient cannot be left alone or allowed to refuse medical care. And you're saying, gee, do you think I should see this in the mountain? But you know what? What you're learning in this class does not apply just for the mountain. It applies in everyday life when you encounter people. Because if you care enough to take a course on medical, you care enough about the compassion with people, and you're going to see life a little bit differently, and maybe you won't, but it'll open your eyes a lot. Patient assessment. Okay, so what do we talk about? Safety, right? Number one is us. Identify the potential danger and do what you need to do to be safe. If you have a violent person, you wait for someone else and you wait for the scene to safe. Always follow your gut instinct. We all have a gut instinct. Some of us say we do, some of us just sort of brush it off and say, oh, I thought that, but I wasn't too sure. So go with that. If something doesn't feel right, it's probably not right. If a weapon is present, do not put yourself in danger, which we know that already, right? Guy pulls out a knife. What are you going to do? You're going to pull out a knife?
Run the other way.
Exactly. You're going to back up. You're going to back up. There's no reason to get in a confrontation with someone that has a knife, especially a weapon. You're just going, whoa, this really escalated. We need to bring this down a notch. You ask for additional resources. Talking to the person at a distance may diffuse the situation. In other words, give space. This way you're not in their space. So step back. At the same time, hit your panic button. Let's see, make mental note about the scene and look for at least 2 escape routes. Anytime you approach a patient, that's what you should do. And anything that you do in life, that's what you should do. When you walk in the park, when you're driving a car, when you're skiing down the mountain, you're always looking to avoid situations. Well, that's what this is all about. Whenever possible, remain near an escape route, which you would. Okay, announce that you're a patroller or an OEC technician and you are there to help. Always do that. Hey, I'm Patroller Patricia, I'm Patroller Lynn, I'm Patroller Arzu, I'm Patroller Kelly. Is there something that I can help you with? Always attempt to speak to a patient at eye level. And if he doesn't want to make eye contact with you, just pay attention to him. Speak in a normal voice, but firm. Don't yell unless he can't hear you. Maintain a comfortable distance, always. Now look at this guy sitting there. Now look at these patrollers. That's a little scary, wouldn't you say?
It could
Hello?
intimidate him.
What?
It could be intimidating to him.
Exactly. I mean, you've got 3 patrollers, even though they're down at his level, they need to back off. You know, he's like overwhelmed. And that's what happens when you talk to children is, remember, they're little, so you got to go down to their level, but give them space. And don't like 3 or 4 people come up and crowd. And that's the worst thing to do. Avoid sudden movements. You may startle a patient. You never know what's going to trigger him. And assume that patient could be dangerous and act accordingly. Okay. If you have a portable communication device, which we always carry radios with us, summon for help. Some 2-way radios were equipped with a distress button. We have that even in our trucks. I don't even know if we have them up in the mountain. Do we have anyone know anything about the radios that we carry?
Yes, we do not. There's a little button, but it is not programmed as a call out distress with the radio mountain. But it appears like it appears like there is one, but it doesn't provide that function.
Oh, geez. We should get that fixed. If you have equipment, forget your equipment, take off. Okay? All right. Situational stressors, such as the witness of the death. Oh, wait, or injuries of a loved one. Oh, that's the worst. Let's see. I'm going to go further with this one. The primary patient assessment begins with a rapid evaluation of the patient's what? Someone tell me, when you're looking at a patient, what are we doing? We're evaluating what?
The ABCDs.
Right. And what else?
Bleeding.
Responsiveness.
Right. ABCDs. It should take you less than 10 seconds. If the patient has been speaking to you, the person has an airway, right? That's what we talk about all the time, is breathing and a heartbeat. So that is good. If there is an ABCD problem, the scene is safe, correct the problem. So scene safety, and you're looking at your ABCDs. Because the patient can change at any time. Okay, with patients with behavioral related problems can range from withdrawn. Okay, signs and symptoms of behavioral emergencies: agitation, which we talked about that, paranoia, speech that appears stressful, bizarre thinking or actions. Have you ever, I don't know, you probably haven't. Have you ever been around someone, all of a sudden they're just really mellow, they're talking to you, and all of a sudden they go off the wall and start screaming? Anyone can relate to that?
Like Tourette's type stuff?
Not so much that, because that's a disorder. They got agitated for whatever reason. They're fine, and all of a sudden something agitated them, and they start yelling and screaming and, cussing you out for it. No? You must hang around with some good people.
It was someone who had anxiety problems.
Yeah. You never know. You could be talking to someone, have a conversation, and all of a sudden they go off. For whatever reason. Mental confusion, hostility, anger, and uncontrollable rage, and uncontrollable crying. Okay. So do not, and I stress that, do not attempt to diagnose the underlying cause of patient's behavior. Instead, protect patient from harm. That's all you can do. Determine whether the patient are in touch with reality, are suicidal, or are anxious, depressed, or dangerous. And I think since we've gone through these chapters and we're at this point, you should be able to recognize this by just looking at someone and reading their face. Because I'm sure that in your everyday life, going out and standing in line or shopping or driving, you can look at someone and see if they're aggressive or they're timid or nothing bothers them.
Hey, Patricia.
Sure.
In this picture, who is having the psychotic episode or is not in touch with reality? Is it the patroller that's fully dressed during springtime and there's no snow?
I know, I was looking at that. I was wondering who was going to say something. Because there's no snow.
He must be hyperthermic.
Very good.
This guy looks like he's on a golf course. Amazing. I don't know who put those together. Evaluating a patient who appears to be having a behavioral emergency, it is important to determine if the patient's in touch. Well, we already know that. Observe the person's appearances and overall demeanor. So look at the way he's dressed. Look at the way she's dressed. Are they clean? Are they not clean? Or should I say not clean? Do they take care of themselves? They don't take care of themselves. Put that in your hat and keep it. And note everything about how a person acts, talks, walks, and thinks. When in a crisis, these individuals are often not oriented to the situation, place, or time and appear confused and disorganized. So these kind of patients you need to remove from the hill. You need to really get them out of the way because you can't do anything more for them. They need to have a higher level of care, which is probably the hospital, a doctor. They need to be evaluated. What caused them to be this way? Are they normally this way? Do they have a condition? You know, when you speak to them, are they listening to you? Is a patient yelling or using obscenities? Sometimes there are people that do that. You know, this couple wanted to take a download, and they said they couldn't ski, but they could ski, but they didn't really want to ski, and they wanted someone to pick them up. So they started cussing. That's really nice. So if somebody starts cussing at you, smile. Say, thank you. I'm here to help you. And they keep on yelling at you. Be very kind. Don't lose your temper. Remember that.
There actually was today, I noticed, and I didn't want to, eavesdrop too much on their conversation, but the girl was speaking Spanish and somebody had come up and was trying to help them. And the gentleman didn't speak Spanish, so somebody else was translating. And it was her first time skiing, and after she had gotten up, she was too afraid to go down the mountain. So in that case, so what do you do? Like, do they just take the lift back down?
Oh, was that on
Yeah, we
Sherwood?
ended up having her go about 50 yards down the mountain trying to ski herself, and we ended up taking her on a taxi.
Really?
Was that on Sherwood?
I don't remember where I saw it, but
yes, that was something that we dealt with today.
It happened on Sherwood.
Huh.
So Kelly, what's happened there? Do you know what a taxi is?
No, I guess I don't.
Right. So because it's customer service, If a person cannot make it down the hill and they're not injured, but potentially could injure themselves or others, we will give them a toboggan ride to the base.
Okay, do you mean the toboggan ride? Okay.
Yeah. And that's what we call a taxi or a courtesy ride.
Oh, okay.
Non-injury, but it's there to protect the guest.
Yes. Okay. Because I thought this, I just was thought, well, what would I say if that was me, if someone asked me that? So I was just kind of putting myself in that guy's shoes.
Yeah.
I didn't know. Okay. Good to know. Thanks.
It's called politeness. Okay. Maintain a safe distance. Calm and encourage patient to talk. Calming a patient having a behavioral emergency. Nice, soft tone voice. Make sure you keep eye contact. Make sure you're watching their body language. Anything changes, back off. That means you're standing too close. If they don't need medical, then they need something else. You want to figure out what you can do to make that patient safe and yourself without getting the patient upset. Patient is yelling. Oh, don't raise your voice. Patient asks you a question, answer the question in a calming voice. Acknowledge and validate that patient seems upset, and repeat that you are there to help. You're always there to help. Encourage the patient to discuss what is troubling them, if you can, and then listen carefully. Then, okay, it's called listening skills. And be honest and don't lie to them. And don't be just judgmental. This is where you're going to obtain a sample history. And what does the S stand for?
Signs and symptoms.
Signs and symptoms. What's the A stand for?
Allergies.
The M?
Medication.
The P?
Previous medical history.
The L?
Last oral
intake.
And the E?
Event.
Very good. Excellent. Let's see. Some patients will be able to talk to you. Some patients won't be able to talk to you. Hopefully they'll have a medical bracelet. If they don't, then you're sort of winging it. Or like I said, find a bystander that find someone that's with them to see if this is normal. We already did anxiety. You already know that. Depression. Depression, they take medications. Some of them don't take them because they don't like the way they feel about it. Are you trying to hurt yourself? Don't be afraid to ask them that. When something doesn't seem right and they're doing something that would cause harm to them, ask them, are you trying to hurt yourself? If they say yes, do you have a plan? Like, what are you planning on doing? If they have a plan, then that's when you definitely call for backup and get all your resources, because you got to get them off the hill. Are they planning on jumping off the lift and hurting themselves? You don't know that for anyone. They going home, take a bottle of pills. Do they have a firearm? They plan on shooting themselves and everyone in the house. You don't know that. Let's see, we talked about that. Patients with disorder, schizophrenic. Okay, we talked about that. Any patient has been abused, whether only recently over a long period of time, may exhibit numerous behavioral symptoms. Okay, so let's see, signs of physical abuse. Bruising. Well, some people, women, they used to wear a lot of makeup so you couldn't see anything. Now, they think it's a tattoo that's been embedded in their skin, and it's okay. Young children, when you deal with young kids, if you see something that's not normal to you, that's your gut telling you something is wrong, make sure you take a note of it and report it. Let's see, injuries that are not age appropriate, like fractures in a child. You know, kids fall, they skin their knees, they skin their arms, they skin their face. So things that are normal to you, the things that don't look right, like if kid's always got a broken arm or he's got a limp because that is not normal, then I would really worry. And kids that are physically abused, they don't like to be touched. Let me see. Obviously, fear of spouse, that's physical abuse. Sometimes they don't, want to talk in front of their spouse, their parent or guardian or sibling. Suspicious injuries that are explained away by the patient or a significant other. Interesting. So there's a lot of physical abuse that people don't report. And if you see something, and I'm sure, Kelly, since you're in the school district, you see things that don't add up, I'm sure you take a note of it and report it. Do you not?
Yeah, we have to report it.
Right. It's the law. And all you're doing is protecting the kid. And kids, they'll say, oh, no, that's not true. And they're afraid to talk. But there's more than people realize. Sexual abuse, I don't know if you're going to see that. You're going to really come into contact with that, but take a personal note of it. Complete the secondary patient assessment, which on patients using the QP, the OPQRST, and the DCAP BTLS. Tell me what those stand for. What's the O?
Onset.
What's the P?
Provocation.
What's the Q?
Quality.
The R?
Radiation.
The S?
Scale.
The what?
Severity.
Severity. Or severity, yeah, I was thinking a scale of 1 to 10.
Oh, okay. Didn't know. So what is the S?
Severity?
Severity.
Okay. Would it be swelling? It used to be swelling.
No, I think swelling is for the BTLS, right?
Oh, that's right. Very good. Very good. And the T? Okay, so tell me what the D stands for.
Deformities.
C?
Contusion.
A?
Abrasions, avulsions.
Okay. The P?
Puncture.
B?
Burns and bleedings.
T?
Tenderness.
L?
Lacerations.
And S.
Swelling.
Swelling.
There's swelling.
Very good. So that's in your secondary assessment. Remember that. And you document it. Please document what you find. Okay? You're going to also do a complete set of vitals. Now, what's a complete set of vitals to you? Someone jump in there. Give me a set of vitals. Like, what would that include?
Pulse. Blood
Okay,
pressure.
yeah, pulse. What else?
Blood pressure.
Blood pressure. What else?
Breathing, rate, rhythm, quality, and depth.
Okay.
And pulse ox.
How about lung sounds? Do we do lung sounds?
I mean, if there's suspected chest trauma, I don't know if we do them every time.
Okay. But that could be one of your vital signs, right?
Yeah.
Okay. And you're going to monitor them frequently, especially if the patient has ingested any drugs or alcohol. So chances are you're going to be checking their vitals every possibly 5 to 10 minutes, trending. You want to make sure that nothing changes, it stays the same. Do they stay at a level where they can compensate, or do they decompensate and now you got to intervene? Continue to treat patients in a dignified, caring manner. Now that's who we are. We have a caring manner, regardless of their appearance, their attitude, or the behavior. Always remember that. You may not like what you see, what you touch, but never show it. And anything that you find, you document it. And if you detect even the possibility of aggression or violence, protect yourself, always. Management. Any questions so far? No? Okay. Make sure the scene is safe, which we already know that. Life-threatening things included external hemorrhaging resulting from self-inflicted wounds. I don't know what self-inflicted wounds would see up at the mountain, except maybe you hit a tree because you're going too fast. I guess that's self-inflicted. Let's see. Until proven otherwise, assume the patient's abnormal behavior results of underlying medical conditions, because you don't know what's going on with that patient. And prevent efforts of entering the patient's safety, avoid hazards, prevent them from harming themselves, others. Continue to calm and reassure the patient as you provide treatment. Empathy. Redirect patient's attention. And we already talked about that. I don't know, each person will have their own, what they'll do to create a diversion so that you can calm that person down. Always call EMS, or if you need security. Okay. Now consider restraining a patient who exhibits violent behavior. Now that's a hard one. How do you restrain a patient that is violent? Do you handcuff them? Do you zip tie them? Do you tie them to a backboard? That's something that will be discussed because of local protocols you have to follow and procedures. Okay, we already know that. Documentation. If you restrain somebody, go ahead.
Just on that slide about restraint and a violent person, let's remember that we're gonna reach outside of our department and probably get management involved.
Right.
And then we can also cover our own CYA if management decides to do something to, restrain the patient. It's on management and not us. Does that make sense? Do you agree with me, Patty?
Yes, it's their property, and we're there just to support it.
Right.
Pat, I got a question about this.
Sure.
What's the protocol in this case? So involve the management if there is this kind of attitude or behavior, as Martha was talking about, or there is other things in more in detail how NOIC technician can do, or so where is the limit where the technician can do, and then before start a law enforcement procedure.
Anytime that you encounter a person that is violent and is a threat to you and others, you definitely call management. You let management handle it.
Okay.
You step back, they come, they deal with it, they call law enforcement. They have it. It's out of your hands. Don't take a swing. If somebody swings at you, try to walk away. Have witnesses that you didn't do it. It's hard that if somebody hits you across the face that you wouldn't hit them. It's a reaction. but you have to remember that they're angry, you're not. And it's just gonna you're gonna escalate it and escalate it. So management will step in and protect you, okay?
Okay.
Don't tell me you're gonna put them in jail, because it doesn't work. Okay, we won't even go there. Restraints are warned out. Don't even go there. Let law enforcement do it. Let management do it. EMS, well, we do it on the rig. 5 people is required to a safety restrain a person, yeah. I mean, we've had 13 officers restrain 1 man, and he was on PCP, so that's pretty bad. So just take, like if you encounter someone and you have an altercation, make sure that you document everything that happened. What provoked it, what happened, what was the end results. Same thing, basically. Just be polite. Try to calm them down. If they don't want to calm down, just sort of step back, make sure you call management. And I'm speaking about the mountain itself. Patients should be placed in supine board to facilitate safe transport. Yeah, if they're at the top of the hill and they become violent and no one, this is, I don't know. I mean, I really say I don't know, because we've dealt with people that, alcohol plays a big role, drugs play a big role, people get into fights, sometimes at the lower half. They're at base medical area, where the restaurants are. Some have been at the top of the hill. We did de-escalate that, but we've called management to continued care, I should say. I don't call care as far as medical, but to deal with the situation, they removed them from property. So
Yeah, Patty, that's exactly it. Like, we're there for medical reasons, and until there is a medical reason that we can deal with, it's in management's hands. So that's a lot of how I think about it. We can sit there and we can support management with a violent person, but until there's medically something we need to take care of, that's all we're doing is supporting management. Is that right?
That's right.
Right.
You do not want to get into an altercation with someone, because you're going to get hurt. And that's not going to be a good day for you. I don't care if you're 6 feet or you're 5 feet. Same thing, but we in EMS, we take care of it, we deal with it, but we have backup. We have police. They're there to help us, to make sure that we're safe. So it's a different situation. It's the same thing on the hill. Management is there. They call Metro, they call NHP, they deal with it. It's out of our hands. We walk away. We may have to write an incident report detailing exactly what happened. Make sure you take note on everything that is said, what the person said to you, what happened. Don't leave anything out. See, documentation should be also considered. Okay, mandatory reporting. You may be required to report abuse, which you are. Kelly said that it is a required thing that we report child abuse, elderly abuse, or any person who in danger. Check with your management and go by what your state laws mandate. Let me see what else. And OAC check. You are not immune to emotional and physiological consequences of managing ill. And that's right. Remember that just because you deal with it every day doesn't make you a super person. There's going to be days when you won't be able to deal with it. There's going to be a day that you're going to take it home, that something happened that you saw. If it affects you, talk to someone. And a lot of the signs of it, the symptoms I should say, is difficulty concentrating, inability to sleep, repeatedly replaying the incident. It's like a nightmare going over and over and over. You get a headache, GI tract problems, profound sadness, depression. This is when crisis intervention should step in. You need to talk to someone. I mean, we see a lot. We see injuries of people. You're supposed to have a happy face. You're supposed to be able to take care of the patient. Sometimes we don't take care of ourselves. We go home with the situation. Did I do it right? Did I cause the patient harm? Especially if you're working a cardiac arrest and that person dies. Did I compress the chest hard enough? Did I give them breaths? Did I do the AED right? You're always going to ask yourself, could I have done more? You got to stop doing that. Stop beating yourself up. This is when you talk to your team members. You talk to professional. Anytime that we have an incident up at the Hill, we have a little debriefing. I'm also a crisis incident, a critical incident stress. I'm CISM. That's what I deal with at AMR. And we do debriefings. So just remember, you're not immune to it because we are human. We live every day our lives. And when we go and we start helping people, we're put in a different mode. Then we go home and we deal with our situations at home. And then we go back to work. Sometimes it's overwhelming. Don't be afraid to talk to someone. Talk to your friends that are really close, or go seek medical, somebody trained in it. And don't be afraid of it. Does that make sense, everyone?
Yes.
Okay. It'll keep your mind healthy. Okay, let's do this case presentation. You received a call to respond to a person having an anxiety attack. You approach, person find you visibly, there's a male who's really upset in his 40s, sitting on a bench alone in an area along a popular trail. The man, who is wide-eyed and appears to be anxious, is yelling at a nearby female who identifies herself as the man's wife. Hey, we see that all the time, right? Upon identifying yourself, the man yells angrily at you. Well, you got in his face. I mean, he's having a conversation with his wife, and you come up, and now you're going to talk. Get away, or I'm going to punch you, while repeatedly clenching and unclenching his fist. Okay, so now, scenario set. Person is sitting there. Another person is yelling at that person. You walk up, it disturbs you a little bit, and you see this person present himself this way. What should you do as a patroller?
Call management.
Oh, very good. Okay. What are you going to tell management?
Is there 2 males here and 1 female? Is that how I'm understanding this?
Right.
Okay.
The man is wide-eyed and appears to be anxious, and he's yelling at a female, which is his wife.
But then there's somebody else sitting on a bench.
No, that's him. Let's see.
You're getting in the middle of a spousal argument, which you don't want to be in the middle of.
Right. Who in his 40s, sitting on a bench along one of the areas. The man who is wide-eyed. Yeah, that's right. It's only 2 people. So, okay, so you called management. What are you going to tell them?
Domestic dispute. The guy was threatening you. All, yeah, just lay it out.
That the guy threatened you?
Well, if he said get away or I'm going to punch you, yeah, that's
Right.
a threat.
So you're gonna call management and say, hey, I heard this guy yelling at this female, didn't realize it's his wife, found that out later. I approached him, asked him what was going on, and he told him to get away. He told me to get away or he's going to punch me. And he showed his fist. So is that what you're going to tell management?
That would definitely be a good start.
Okay, so that's one. Give me someone else. What would you do?
Isn't that the definition of assault?
Yes. But did he punch you? Not yet, right?
No, that's battery.
So what would you do?
Maintain space and identify your 2 escape routes and make sure those both stay open.
Right? Would you identify yourself?
Yes,
Okay. Would you be calm?
of course.
Okay. Let's see what happens in the next slide. Because if you call management, see what's going on before you call management, okay? Let's see. But keep them on high alert. Okay. Your immediate concern is for your own safety, which we always do. As other OEC technicians clear bystanders from the scene, you attempt to diffuse the situation using a calm and caring tone. You assure the man that you are there to help, right? You identified yourself. Within a few minutes, he begins to settle down, and then he starts to cry. Uh-oh, we're in trouble. So now you've diffused it in that sense. He's paying attention to you. You're calm, you're caring, and you're speaking to him. But he's also speaking to you. It sounds like he's having a breakdown. After obtaining his permission, you carefully approach the man in a non-threatening manner. As you begin to build trust, you learn that the patient's brother died 1 year ago today. See? The man and his wife were hiking up to the top of their brother's favorite ridge, where they plan to release his ashes in the wind. Today is patient's first time hiking in over 5 years. He's still upset and repeatedly says, I can't believe that he's gone. So he had his own crisis. And it's for you as Sherlock Holmes to figure it out. So by speaking to him in a very calm, reassuring manner that you're not there to hurt, that you're there to help, he basically divulged everything. Wouldn't you say so? So do you let him release his ashes in the wind?
Of course.
Yeah.
But you need a special permit. It's Forest Service property. I'm kidding.
What is it? Don't be downwind of it? Okay, let's go to the next. Patient is now breathing deeply and hard and continues to cry. So now you've got someone that's really upset. He is alert and oriented to place, date, and time. During your assessment, you learn that the patient has not eaten since last night. So what does that tell you?
He's
Low
undernourished.
blood sugar.
Hypoglycemia.
But he's not a diabetic.
Yeah, but he's exerting himself more than he has in 5 years, and he's not properly nourished. So
Right.
Dean, I like that because on the last slide when he was like, I haven't hiked in 5 years, I was thinking he's hypoxic and that's bringing on some moods because he lack of oxygen. So, and a lack of sugar. So,
Very good. It is now midday. With prompting, you get patient to agree to eat an energy bar. Very good. You continue your assessment. You ask him, does he have chest pain? He denies it. He complains that his lips and hands are tingling and he feels like he may pass out. Okay, so what are we talking about? Hypoxic.
Mm-hmm.
Okay. Hasn't eaten really. The physical assessment is unremarkable for obvious trauma, which we knew we wouldn't find, although patient's fingers are now tightly contorted. So what is going on?
Anxiety.
Exactly. Exactly. What happens to the body?
Freezes up.
Yep, it does. He begins to become agitated because he cannot open his hands. Everything constricts. He denies that this has ever happened before or having used any mind-altering substance. Do we believe him? Yes or no?
Yes.
You have to. He agrees to let you take his vitals, which is his heart rate is 108. His blood pressure is 126/72. That's not bad, would you say?
No.
No, his heart rate could be a little bit high, but you know, we don't know what his normal heart rate is. Respirations are what?
Accelerated.
26. Is that good or bad?
It's bad. It could come down.
The CO2 level, you know, his skin is somewhat sweaty and warm to the touch. Okay, so now we have a picture. We painted the picture of this person. What should you do now? There's your assessment. What are you gonna, how are you gonna treat it?
Keep
What about
talking.
giving him oxygen?
Give him oxygen?
Yeah.
Okay, all right. So why are you gonna give him oxygen?
I don't know.
Okay, well, I just want to put you in the right. He looks like he's got enough air going in and out. He's just retaining his CO2. So let's do this.
Maybe have him just take deep breaths and slow down.
Very good. Excellent. So, and when you take deep breaths and you slow down, what happens to your respiratory rate?
Goes down.
Exactly. What happens to the skin?
Goes back to normal.
Right. He stops sweating unless he's really, really hot and he's got a high fever. Okay, you try to calm the patient, which, you know, you already said it, Kelly. Slow his breathing. After several minutes, he's calm and he stops crying, right? And why do you think he stops crying?
Because he's calmed down.
Right, and he's focusing on his breathing, right?
Mm-hmm. And
So
not everything else.
right. So you sort of got him thinking of something else. The tingling subsides, so he now has full use of his hands, now that anxiety, and no longer feels faint. He feels better. He drinks the bottle of sports drink in his backpack. Oh, that's pretty good. He brought a sports drink. Embarrassed. He's embarrassed. He tells you that he has been very stressed since his older brother died. Okay. And I'm sure that you have the compassion to understand that. And he thanks you for your kindness because you were very considerate, very compassionate, and you were caring, right? You and another OEC tech accompany patient and his wife to the top of the ridge, which is only a quarter-mile away. Oh, you guys are so nice to do this. Respectively at a distance, you watch as the pair open. What did we talk about, Martha?
It's Forest Service property and you need a permit to do that.
Oh, they opened up the urn and threw the ashes off the ridge. And they hugged each other. And they went through a healing process. Think about that. And this emergency, behavioral emergency, was a combination of anxiety and grief. And you manage the patient and his behavioral. And through the kindness of your heart, you de-escalated the whole situation. And Len, you want to call management. That's it. Any questions? Hello?
No questions.
Nothing? See how easy that was? Let's hope that all our patients are that way. But like Martha said, we can't have urns full of ashes in Forest Service.
I wouldn't stop them, but that was sort of a joke.
I know.
All right.
I wouldn't stop
Don't
them
ask, don't
either.
tell.
Just stay
Right.
open.
I bring a bottle of champagne and said, let's celebrate, the life,
Right on.
all the good things. Okay. Other than that, that's all I have to share with you. Just remember to take care of yourself. Try not to take everything home with you that you've dealt with when you treat people, no matter where you're at as far as medical. Also remember that you do deal with people that have behavioral problems. Some are induced and some are not induced, self-induced. And you just have to figure out how to control that or protect yourself so that it doesn't take you down. Okay? And I would say Happy New Year.
Yes, Happy New Year.
And I'll see you next year.
Happy New Year, everyone. And I'm sorry that my technology doesn't work from up here at 8,500 feet. But I'm glad to join this class, and soon I'll get to meet you all in person.
Right. That's what we're planning in the middle of January. So if you have any questions, concerns, complaints, forward them. We may answer you, we may not, but we will try. Okay, Happy New Year. See you next year.
Happy New Year. Thank
you. Rizzo is next.
Be careful.
What?
All. Have a great year.
Okay, be safe and don't drink and drive.
Thanks, Patty.
Okay, thank you.
Thank you. Bye.
Bye.
Thank you.
See y'all on the mountain.
I know, what a blessing.
Hey, good night, Patty, unless you got anything for me.
Nope. I am going to bed. I have to be on the mountain tomorrow early. So I'll see you. You be careful, Martha. Be
I
good.
will. I will be your first responder, or I'll be your ambulance driver tomorrow. Oh, you guys still have MediQuest. Forget that. I'll be in Kyle. I'll see you when I see you.
I'll see you when I see you. Stay healthy and take care of your dog.